Welcome, everyone. I'm Dr. Pam Dhillon, and this is Dr. Parishi. I practiced as a general dentist for many years, and now I'm transitioning into orofacial pain and oral medicine. Today, we are talking about obstructive sleep apnea, or OSA, and why general dentists should care about it. This topic is very personal to me. My mother, who was my best friend, passed away at the age of 63 from a heart attack. Looking back, she had the signs that I did not fully connect at the time, like snoring, fragmented sleep, daytime tiredness, fatigue, and trouble concentrating. If I had known then what I know today, I believe I may have recognized those warning signs sooner. This is why I want general dentists to ask themselves, does this sound like someone you know? Because a simple question in the dental chair may help change someone's life. Many people think sleep apnea only affects overweight, middle-aged men. That group is certainly at risk, but OSA can also affect women, younger adults, postmenopausal women, and even children. As dentists, we see patients regularly. They may come in for a cleaning or filling, but we may notice signs that point to a bigger health problem.
Absolutely, Pam. Thank you for sharing that with us. It really shows that why this topic matters just beyond dentistry. I'm Dr. Parishi Marfatia. I'm an internationally trained dentist from India and a current graduate student at the orofacial pain program at the Herman Ostrow School of Dentistry at USC. My background includes general dentistry training in India. What interests me about orofacial pain is how connected the mouth, airway, TMJ, sleep, and overall health are. As dentists, we look inside the mouth every single day. But sometimes these findings can tell us much more about what is happening in the mouth. Sleep apnea is a great example of that. Today, we'll see how dentists can recognize possible signs of OSA, what questions to ask, what screening tools to use, and when to refer.
OSA is common, and many patients go undiagnosed. If you see 20 patients a day, there's a good chance that some of them may have obstructive sleep apnea and not know it. Untreated OSA is linked with serious health conditions such as high blood pressure, heart attack, stroke, diabetes, depression, memory problems, daytime sleepiness, and motor vehicle accidents. So this is not just snoring. This is a medical condition that can affect the whole body.
Exactly. Dentists do not diagnose sleep apnea, but we can recognize the risk. Snoring may sound harmless, but in some patients, it can be a sign that the airway is narrowing and collapsing during sleep. The dental office is a great place to actually start noticing these clues. We see the tongue, the palate, the tonsils, the bite, the tooth wear, dry mouth, and other signs of mouth breathing. So our role is to screen, ask better questions to our patients, document what we see, and refer to our patients to the right provider. Obstructive sleep apnea happens when the upper airway collapses during sleep. The patient may stop breathing completely, which is called apnea, and when the patient stops breathing partially, it's called hypopnea. When this happens, oxygen levels drop, and the brain briefly wakes up, trying to gasp air and get the airway to reopen. The patient may not remember waking up, but this can happen multiple times during the night. So even if they sleep for 7 to 8 hours, they may still not feel as refreshed. They may still feel tired. Patients may say things like, I wake up exhausted, I need coffee all day, I sleep during watching TV, or I feel sleepy during driving. These symptoms make us think more and should make us think more as dentists about the sleep quality and not just the sleep quantity.
That's such an important point. A patient may think they're sleeping enough, but their body may be struggling all night long. So what can dentists do to assess these symptoms? This is where simple screening tools can help.
So in a dental office, screening can be very simple. We can do 3 things. First, we should look at the airway-related findings during the oral exam. Second, we should look at and ask better sleep history questions. Third, we should use simple screening tool like the Epworth Sleepiness Scale and the Stop Bank. These tools do not diagnose OSA, but will help us evaluate better and help us decide if the patient might need a further sleep evaluation referral. So, going towards the Epworth Sleepiness Scale, the scale will Ask how likely a patient is to fall asleep in daily situations. For example, sitting and reading, watching TV, riding as a passenger in a car, sitting quietly in a public space. These scores range from 0 to 24. A score of 10 or higher suggests excessive daytime sleepiness. This does not diagnose sleep apnea, but it tells us that the patient may need a referral and may not be getting enough restorative sleep.
I like the Epworth because it uses real-life examples. Patients may not say, I have daytime sleepiness, but they may say, I always fall asleep while watching TV. That gives us a simple way to start the conversation. Another useful tool is the Stop Bang questionnaire. It has 8 yes or no answers. STOP stands for snoring, tiredness, observed stop breathing, and high blood pressure. And the BANG stands for B is BMI over 35, A, age over 50, N, neck circumference over 16 inches for women, and over 17 inches in the men. And G is male gender. A score of 0 to 2 is low risk, a score of 3 to 4 is intermediate risk, and 5 to 8 is high risk. This can be added to any medical history form or completed while the patient is waiting.
The nice thing about Stop Bang is that it is quick and easy. If a patient screens positive, we can say, your answers suggest that you may be at risk at a sleep-disordered breathing. This does not mean you have sleep apnea, but it would be a good idea to discuss this with your physician who may later refer you for a further sleep study or a polysomnograph, or to refer to a sleep specialist. That wording is important because we are not diagnosing, we are screening and referring.
Now let's talk about what dentists can see during a routine exam. Every comprehensive exam and hygiene visit gives us a chance to look for airway-related signs.
Definitely. So during a dental exam, we can look for several findings that may increase suspicion for OSA. These include a large neck circumference, high BMI. Although thin patients can also qualify or have OSA, large tongue or a scalloped tongue, narrow or high-arched palate, protruded lower jaw, mouth breathing, dry mouth, heavy tooth wear or bruxism. None of these findings diagnose OSA alone, but if we see several of them together, we should ask more sleep-related questions.
One simple airway observation is the Friedman-Tun position, which is similar to the Malapati classification. Just ask the patient to sit upright, open their mouth, and stick their tongue out without saying. Then look at how much of the soft palate, uvula, and back of the throat that you can see. If very little is visible, such as Friedman class 3 or 4, the airway may be crowded. This does not diagnose OSA, but it adds to our overall risk assessment.
Exactly. One finding alone is not enough. A crowded airway does not automatically mean that the patient has sleep apnea, and a normal-looking airway does not completely rule it out. That is why we combine what we see, the symptoms, the medical history, and the screening tools.
Dentists see bruxism every day. Patients say, my friend tells me I grind, I wake up with jaw pain, my teeth are wearing down, I keep breaking restorations. Stress can play a major role. But we should also think about sleep-disordered breathing. Sleep bruxism and OSA can occur together. Sometimes grinding may be related to brief arousals from sleep or the body just trying to reopen that airway. So when we see a heavy grinder, we should ask about sleep.
Yes, not every bruxer has sleep apnea, and not every OSA patient grinds, but the overlap is quite important. As dentists, we should be more careful to not jump to a night guard recommendation straight away without asking the question why the patient may be grinding. If a patient snores, wakes up tired, has morning headaches, or has witness apneas, we should screen before making an appliance. Some questions that we may ask as dentists during a routine visit is, do you snore loudly? Do you wake up tired even after having a full night's sleep? Do you feel sleepy during the day? Do you wake up with dry mouth? Do you clench during night? Do you have jaw soreness? These questions are simple, but they can reveal a lot.
And sometimes the spouse, roommate, friend gives the most accurate, important information. A patient may say, I sleep fine, but that spouse or friend may say, actually, you snore loudly and stop breathing. That's a major red flag.
Yep.
One thing I learned in general practice is that OSA does not always look the way we expect. I've seen thin women, young adults, athletes, and patients with normal BMI who were diagnosed with sleep apnea. If we only screen overweight, middle-aged men, we'll miss many patients.
A lot of them. That is very important, especially for women. Women may not always have classic symptoms like loud snoring. They may report fatigue, insomnia, mood changes, morning headaches, or poor concentration. Postmenopausal women are also at a higher risk. And also from an orofacial pain perspective, poor sleep matters because it can increase pain sensitivity. If a patient has TMD, headaches, facial pain, muscle pain, and poor sleep, their pain may be harder to manage. So, if we suspect OSA, we should keep the process simple. Use stop bang, use the Epworth Sleepiness Scale, document the symptoms, the oral findings, document medical history like the blood pressure, the hypertension, the diabetes, stroke history, depression, anxiety, and the daytime sleepiness too. Then explain the concern to the patient calmly. We can say, I am seeing some symptoms that may be associated with sleep disordered breathing. This does not mean you have sleep apnea, but I recommend discussing it with your physician or a sleep specialist. The key point here is the dentist screen and the sleep physicians diagnose.
Exactly. The sleep physician will decide whether the patient needs a sleep study. The polysomnogram records breathing stages instead, but if the home test is negative, unclear, technically inadequate, or does not match the patient's symptoms, the patient may still, and AASM guidelines state that the PSG is the standard diagnostic test when there is a concern for OSA. The sleep physician will decide whether the patient needs a sleep study. The gold standard is an overnight in-lab polysomnography called PSG. The PSG records breathing, oxygen levels, brain activity, heart rhythm, body movements, and sleep stages. In selected uncomplicated adult patients, the physician may order a home sleep apnea test instead. But if the home test is negative, unclear, technically inadequate, or does not match the patient's symptoms, the physician may still send the patient for an MLAD PSG. AASM guidelines state that the PSG is the standard diagnostic test when there is a concern for OSA after a comprehensive sleep evaluation. After diagnosis, treatment may include CPAP, oral appliance therapy, weight management, positional therapy, surgery, or other medical care depending on the patient.
Yeah, I agree.
Dentists may also be involved in oral appliance therapy for appropriate patients. Mandibular advancement devices can move the lower jaw forward and help keep the airway open during sleep. But oral appliance therapy should be done after a proper diagnosis and in communication with the sleep physician.
This is where the orofacial pain specialist comes into perspective and is helpful. Before advancing the jaw with an appliance, we should consider TMJ, muscles, occlusion, the range of motion, pain history, and bruxism. If a patient already has TMJ pain, limited opening, facial pain, headaches, or complex bruxism, referral to an orofacial pain specialist can be really helpful. The airway matters, but the joints and muscles matter too. Dentists can also have a very simple sleep hygiene advice to the patients. This does not replace diagnosis or treatment by a sleep physician. Patients can be encouraged to have a consistent sleep schedule, avoid caffeine late in the day, limit alcohol at night because it can worsen airway and collapse it. Sleep in a dark, quiet room. Avoid using screen and phone time. Avoid nicotine and sleep on the side if positional sleep apnea is suspected. Talk to a physician about chronic nasal congestion. These steps are small, but patients often appreciate it coming from a general dentist.
And it helps patients understand that sleep is part of health. They may come in thinking the visit is only about their teeth, but we can help them connect snoring, fatigue, dry mouth, headaches, and overall wellness. That builds trust. From a practice standpoint, airway screen does not have to be complicated. The stop bang and Epworth can be added to the medical history update. Clinical findings can be documented during the exam. If there is concern, the dentist can refer the patient to a physician or a sleep specialist. The referral should include symptoms, screening scores, oral findings, and relevant medical history.
And we should also be consider our wording while referring. We should not say, you have sleep apnea. Instead, we can say you have some signs that may be associated with a sleep disordered breathing, or your screening score suggests that a formal sleep evaluation can be helpful. A sleep physician can decide whether you need a sleep study, or you can use a home sleep apnea test when appropriate. That keeps us within our role while still helping the patient to get appropriate care.
Many patients today can use sleep tracking devices like the Apple Watch, the Oura Ring, Fitbit, or any of the snore monitoring apps on your phone. These tools do not diagnose sleep apnea, but they may help start the conversation. If a patient says their app shows snoring or oxygen drops, we should take that very seriously and recommend proper evaluation.
Yes, definitely. Technology can help make patients more aware of their sleep, but we can always tell them that this device does not diagnose sleep apnea. But if you are noticing repeated snoring, poor sleep quality, or oxygen changes during the night, it is worth discussing it with your sleep physician. Formal diagnosis still needs proper medical evaluation.
Let's each share 3 key takeaways. Takeaway is do not ignore the snoring. Second, use the simple screening tools like stopping and Epworth. Third, remember that OSA can affect many types of patients, not just overweight middle-aged men.
That's completely true. My first takeaway is, as dentists, we should look beyond just the teeth. A scalloped tongue, dry mouth, mouth breathing, bruxism, high-arched palate, and a collapsed airway may be the clues. The second takeaway is to connect the sleep with pain. Poor sleep can worsen headaches, TMD symptoms, muscle pain, jaw pain, and facial pain. My third takeaway is know your role. Stay within the role, but also help the patients. Dentists screen, document, and refer. Sleep physicians diagnose. OFP specialists can help when sleep concerns overlap with the TMJ, facial pain, bruxism, or oral appliance concerns.
As I move away from general dentistry into the oral facial pain and oral medicine, one of my goals is to help the general dentist understand how much impact we can have on overall health. Every hygiene visit and comprehensive exam is an opportunity. By looking beyond the teeth, we may help patients get the care they need and possibly even save their loved ones.
I agree. And thank you for joining with us today. We hope this discussion was encouraging and it helps dentists to start adding the simple airway screening questions to their everyday general practices. A simple question can make a big difference. Sometimes the most important thing is not to restore a tooth, but sometimes it is recognizing a health condition that has been hiding in plain sight. Thank you for listening to us. We'll see you next time. Bye, John.